The data on protein intake in terms of both preserving muscle mass or increasing muscle mass is just not there for diets higher than about 1.2 to 1.5 grams per kilo. It's just not there. So everybody says that's what you should do, but I have never seen anything, even with these new GLP-1s, that the higher protein is absolutely working any better than enough protein. So if you can get people to eat 1.2 grams per kilo, that's really quite a lot. People are not eating that. And you can tell how much they're eating by doing a 24-hour urine and finding out what their urea nitrogen is.
From the presentation, the last slide or so before the jokes, there's the part of when we're doing the monitoring of response for resmetirom. Yes, so the SGLT2, the GLP-1s, yes, definitely used as add-ons for patients who have not had adequate response at the 12-month period of assessment of your resmetirom response use, yes. So they do have a definite role to play. There's been a lot of studies, so I didn't finish the entire presentation because it's a lot broader. So the truth is that personally, there was my last 3 slides which I didn't do were based on food for thought, what I call food for thought. So there's a lot of possibilities with fatty liver disease that still exist. And I do believe that a lot of the other older molecules which have been used in the past do have a role to play. And here's the role that they have to play. I think the FDA has been focusing on reversal of fibrosis. However, as you saw on the progression of fatty liver to hepatitis, steatohepatitis, to cirrhosis and hepatocellular carcinoma, we have a very good reversible period. So if we can stop the worsening of the liver disease at steatohepatic level, then why not? I find that we are focusing too much on fibrosis and we're leaving out the hepatitis phase. And the question to me I'm asking myself is why? Is it policy? Is it politics? Is it financing?
I think if we actually borrowed the registries from childhood, one of the things that Ministry of Health currently doing is that we're going to start a super highway with regards to data. And while we're afraid of data, that is where we're going to learn the lessons. So if you're already picking it up, that pregnant woman who comes and is already obese, attending antenatal clinic, and you already know she's at risk, that's the time you start involving multidisciplinary care. Now if I follow her up as the lady, and then the child is actually followed up at the pediatrician, by the time that child is 18, we already have so much data. The other thing that we are doing is working with ministries, like Ministry of Education. When it comes to the schools, we are saying playgrounds have to be mandatory. But you can't say that if the curriculum does not specify that there has to be protected time for physical activity. Number 2, when it comes to our Kenya Bureau of Standards, you notice then in terms of food labeling, they're a bit shy to actually come out and actually talk about, can we know about the calories that is involved in them? So we allow so much of this to go unchecked, and that is the problem. And then what we found that is that has been interesting is like in Aga Khan, they introduced certain days, like in some of the schools, they introduced days where you're only allowed to bring a vegetable as a snack.